Alright, the next thing we're going to talk about is prioritization of nursing care. So our objectives here are to define prioritization. We're going to talk about what it is, and then concepts that surround good prioritization. How do you know, what should you do first? How do you decide what should you do first? We're going to compare and contrast some of the methods that you can use to prioritize your care, and then we're going to talk about principles that you should implement, things that you that you should use to help decide who should you see first. Alright, what is prioritization? Okay, it is organizing activities according to the order in which they should be done. Okay, so there are many ways that we can do things. Some of the and many reasons why we do what we do. Okay, why we put one thing important, one thing over the other, and how one person prioritizes may not be the same as another person, and that does not make it wrong. Okay, this is where the flexibility and the open-mindedness comes in that I was talking about with leadership, because there's more than one way to skin a cat. Alright, no two nurses think the same, and no two nurses are going to do things exactly alike, even if they have the exact same patients, and that's okay. So you might be thinking, well, how am I supposed to figure out what I'm supposed to do? Okay, and how am I supposed to figure out how NCLEX wants me to answer that question correctly? Okay, so there's basic principles that we're going to talk about that any nurse can apply, and it will help you prioritize patient care, but it will also help you on NCLEX know how to answer the question appropriately. Okay, so the basic ways that we prioritize care, and this is especially true for the NCLEX exam, there are basic ways that they look at patient situations. Okay, and that's these methods that are listed here: emergency, trends versus isolated findings, actual before potential, and so on. I'm going to go over each one of these. Okay, as I said, there's many ways to organize your care when you're working. The bottom line is always assess first and always evaluate last. Okay, you've got to assess the situation, assess the patient first. You've got to assess. You've got to see what's going on. That's what assessment is. It's me going in the room or me going to the patient and information gathering to find out what's the situation. I've got to have the details. Okay, I need the facts, just the facts. And then as you move through the nursing process, diagnosing, planning, intervening, evaluation always comes last. And so the very last step is always evaluate to see how things worked. Alright, let's talk about emergency first. A, B, C, D. Airway, breathing, circulation, and disability. Okay, this is basic CPR. Annie, are you okay? Establish the airway first. Airway, airway, airway. Airway is always first. Let me say it again. Airway, airway, airway. Airway is always first. In NCLEX style test questions, if there is an answer that's related to the airway, then it's top priority. It doesn't matter about the heart rate if your patient doesn't have an open airway. It doesn't matter they're bleeding to death if they don't have a patent airway. Okay? So assess for patency, establish an airway, oxygenate. That even comes before breathing. Okay? So airway first, then breathing. Once the airway is open, then you move on to the breathing pattern. Is it good enough? Is it effective? Is it ineffective? Is the patient apneic? Can we fix it? Is it an obstruction? Is it secretions? Is there something that we can do to enhance the breathing or make it better? Are they oversedated? Can we give them some medicine? What can we do to make the breathing better? Then circulation, signs of perfusion, extremity, temperature, pulses. Is the patient having an arrhythmia? Do they have a low blood pressure? Is there something that, again, what can we do to enhance circulation? What can we do to make circulation better? And then the D is disability. And that can be a wide variety of things. So the main focus here is to slow down or stop or prevent disability. Okay? So an example of this would be that, let's say a patient who has high blood pressure. We want to intervene. We want to teach them about blood pressure and how to control it so that they don't end up having renal damage over time, or that they don't end up having vision loss over time from uncontrolled hypertension. So the disability may not necessarily be a crisis or an immediate acute situation like airway, breathing, and circulation. The disability is really more aimed at prevention of complications from a disorder, okay? But the bottom line here to all of these is you've got to assess first, okay? You've got to assess first. Our next method is called trends versus isolated findings. That means, have you noticed a pattern? Have you seen a trend that's not okay? Or is it just one blood pressure reading? I have a saying, one blood pressure reading does not hypertension make. One blood sugar reading does not diabetes make. And that is the truth. You've got to do trending. You've got to check that blood pressure more than once. You've got to do serial, as SERIAL, as in a series of readings to establish a pattern of either normal or a pattern of abnormal. I tell people this all the time. You cannot go to Walmart and sit down at the blood pressure machine and take your blood pressure one time and then freak out and say you're hypertensive. You've got to take blood pressure at the same time every day for at least a week to establish a pattern. Okay? So recognizing a gradual change or a deterioration over time is key, and that's where those trends come in. One low blood pressure is, that's resolved itself is not near as important as a patient whose blood pressure has continually been increasing over the last 12 hours, or one whose blood pressure has been continually trending lower and lower and lower over the last few hours. Okay? It's the trends that really mean something to us. A patient's pain that's not resolved with current treatments should always be seen before somebody whose pain pills are effective each time you give them. That's a trend. You know that, yes, that person is having pain, but their pain medicine works very well for them, and when I give it, I know they're going to be okay, as opposed to someone who we've been working with them, we've given them medications, we've done other non-pharmacologic things, and they are still hurting. So, that's a trend or a pattern of behavior. Trends signify something more important. They signify a deeper, more serious problem. So further assessment needs to be done. Okay? And typically, the healthcare provider, doctor, practitioner, whoever, needs to be notified. Okay? So that's very important to remember. And guys, I'm not just telling you this for a test. You will do this in clinical. I will ask you over and over and over again, what are the trends? You're going to come to me and you're going to say, my patient's blood pressure is high. Okay, what are the trends? What have they been running? You've got to know over the last few hours or through the night or yesterday, what did they run? And you've also got to correlate the trends with time of day. You will see patients who run low blood pressures in the morning and then gradually increase through the day. You will see people who maybe wake up with high blood pressures and they gradually deteriorate or drop as the day progresses. So you can always correlate your trends to the time of day and to activities such as getting out of bed, getting up, taking a shower, walking the halls, medication administration. Maybe the patient wakes up with very high blood pressure. You're looking at it from the day before. They woke up with a really high blood pressure, and then about 10:30 in the morning, all of a sudden their blood pressure was really low or had dropped, a significant amount. Well, maybe they got medications at 9 a.m. So you always want to look at the trend and then correlate those trends with activities and behaviors, okay? So that's assessment. We're also going to trend level of consciousness. You can't just walk in a room and your patient, be groggy and freak out and say your patient has an altered neurostatus. Okay? You've got to look at their pattern of activity, or pattern of behavior. Okay? Okay, the next method is actual problems versus potential problems. I like to say, is it real or is it a possibility? Okay? Now that can go both ways. I like to say, we'll jump off that bridge when we get there. Okay? Meaning, if we don't have a problem, let's don't create one. But by the same token, if we don't have a problem, we still have to think it through and be prepared in case we do develop that problem. Okay? But you've got to ask yourself, is it an actual problem? Is something actually going on? Or is there the potential that something will develop? So generally, we're going to treat a real problem over a potential problem. If you've got a patient who's actively bleeding, of course we're going to deal with that before we would handle a patient who might be in pain because their pain medicine may not work. You get what I'm saying? In general, a problem that already exists should be taken care of before a problem that doesn't exist or potentially may never happen. Okay? So let's don't borrow trouble. If we don't actually have a problem, let's don't create one. But let's anticipate what we would do if that problem did happen. Okay, example. Two people come in when their diagnosis is possible GI bleed or rule out GI bleed. Both of them have a low hemoglobin. One patient is actively vomiting blood and the other one is not. We are going to take care of the patient who's actively vomiting blood before we take care of the one who's not. Even though both of them have a low hemoglobin and both of them, came in for the same problem. We're going to deal with the real problem versus the potential. The next method is systemic versus local, or life over limb. Systemic issues, meaning they involve the whole body system or the whole body, always are a higher priority than situations that only involve an isolated area or part of the body. Okay? So we always need to fix a systemic issue before we address a localized issue. For instance, you have an emergency situation, a car wreck. The patient has a broken arm. You can tell that they have a broken arm, but they're not breathing. Well, we've got to fix the breathing issue first. We've got to deal with airway way before we deal with broken arm. Who cares if they have a broken arm if they're not breathing? Because if they're not breathing, they're not alive. All right? So, always deal with a systemic issue first. Now, in the absence of airway, breathing, circulation, and disability problems, or even airway, breathing, and circulation problems, you always address a local issue. It is a priority if there are no other systemic issues currently happening, because if you don't address the local problem, it will eventually lead to a systemic problem. Okay? So, in an acute situation, systemic always falls over local. And then once the patient is stable, you deal with the local issue so that it does not in turn become systemic. The next method is acute problem versus chronic problem. So I've been saying an acute situation a whole lot in this lecture so far. Acute meaning it's new, it's happening right now, right in front of me. It might be a situation or a diagnosis that the patient has never had before, or it could be that they've had this problem in the past, but they've been okay, and then all of a sudden they've had a flare-up or an exacerbation, and it's an active problem. And what I mean by that is, let's say, like with asthma patients, asthma is considered a chronic disease, a chronic disorder, but the patient can be controlled. Their asthma can be controlled. But that means, that doesn't mean that they'll never have another asthma attack. So when they do have an asthma attack, that is an acute exacerbation of a chronic problem. And so we always deal with acute problems first. So if it's a new problem that they've never experienced before, a new injury, a new disease process, a new diagnosis, we always, always, always assess and care for that first. If it's a change, if it's an acute or a new change or a difference in the chronic condition, we still deal with it first. That's the asthma scenario. Okay? People who have chronic health issues that are somewhat controlled, their body has actually adapted, has learned to adapt to that chronic condition, and they have some level of adaptation. So we don't have to address them as quickly as we would someone who has brand new onset of something or has an acute change. So acute is always first. Assessment is the key. You've got to assess and get to the bottom of that new that new development or that change and see what's happening. Make sure it's not life-threatening. When you have chronic conditions, something like diabetes or hypertension, many times the patient is very familiar with their own body and how they feel. They know how to take care of themselves. They can tell when their blood sugar gets too low. They can tell when it gets too high, and they can intervene appropriately. So, those chronic conditions are not as high a priority. The bottom line is to see the new patient, the new diagnosis or the change or the unpredictable situation first before you see a patient that has a predictable or chronic issue. All right. The next method is to utilize Maslow's hierarchy. We all remember Maslow: physiologic, safety, social, esteem, self-esteem, self-actualization. Basically, these can be divided into the physiologic and safety, those go together, and then the psychosocial, which would be your social category, esteem category, and self-actualization. We always deal with physiologic before psychosocial. Physiologic always comes first. You always rule out a physical need, a physical health problem, before a psychosocial problem. Now, many times, psychosocial issues can manifest in physical illness, and we would assess, again, the first step here is assessment of those physical complaints, physical manifestations, to make sure that the patient is stable. And once we determine whether or not the patient is stable, then we can begin to move into addressing the psychosocial issues. All right, so a little review. Physiologic is going to be things like food, oxygen, sleep and rest, excretion, sex drive. Those are all physiologic, basic physiologic components. And then with safety, it involves things like shelter, removal from danger, fear factor. Those always have to be addressed first. I can tell you that on NCLEX, aside from physiologic, safety is a huge category. They will, many of your questions have a safety focus to them. And you always err on the side of safety. That's always going to be your priority. And physiologic is going to be, airway, breathing, circulation, and then safety. So the social category is love and belonging, affection, acceptance, being part of a group. Esteem is self-esteem. And self-actualization is achieving one's potential. Okay? So again, always physiologic over psychosocial. Another strategy that we can prioritize by is time management. I love time management strategy because it's not always that your patient is not doing well. With the ABCD method, that kind of lends itself to an unstable patient. Life over limb, again, kind of lends itself to an unstable patient with an acute problem. With time management, that gives us a little freedom to organize and coordinate our care, maybe not necessarily on whether or not the patient is unstable, but according to time. What can we get done first? What's going to take us the least amount of time to get it done? And what's going to take the most amount of time to get done? So we can kind of structure our care or organize our activities based on time management strategies. Is there something that needs to be done immediately? Or when I come in the morning and I get report, I begin to prioritize things and say, okay, what do I have to do first? What has to be done immediately? Is there a patient who is puking their guts up and they need some medicine right now? Is there someone who's in excruciating pain and they need their pain medicine right away? Is there a patient that's fixing to go to surgery and the OR has already called and I've got to go, get the last little bit of their preparation done so that they're ready to go when the OR comes? What needs to be done before anything else at that time for that patient? Then you have the things that can be done within a specific time frame. These are things like medication administration. Medications are ordered for a certain time. And we have 30 minutes before and 30 minutes after that time to give that medication, and it's still considered on time. We have that 30-minute window on each side. So that's a specific time frame. Is there something that needs to be done before breakfast? One touches or glucose checks. We all know that insulin should be given before the meal. It doesn't do any good to give your patient their breakfast tray and then 30 minutes later check their blood sugar and treat their insulin, treat them with insulin. That's not best practice. So what needs to be done within a specific time frame? What can be done by the end of the shift? It has to be done. It's just not a priority for right now. And then what can be done in the least amount of time? What can be done the quickest? Is there something that, it's not necessarily has to be done immediately, but I can do it very quickly and I can get it knocked out, crossed off my list, and move on and not think about it anymore. Sometimes those are the very things I do first. Unless there's not any kind of something that needs to be done immediately, any kind of top priority pressing thing like pain medicine or nausea medicine or a patient going for a procedure, if I don't have any of that stuff that has to be done immediately, then I just begin to look at things in terms of, little insignificant, the nitpicky things that I just don't want to have to deal with all day, and so I just get them done and get them crossed off my list. Those are little things like checking the crash cart. It has to be verified every morning. It has to, we have to make sure it works. It might be writing patient assignments up on the marker board. Let me get that done and get it over with, and then I don't have to think about it for the rest of the day. It may not be a big deal. It's just a simple and easy task that can be done first. So when you're looking at time management, in terms of organization, and prioritization for your day, still remember all of the other ways. A, B, C, D always takes precedence over time management. Okay? But if all your patients are stable and you don't have anything pressing to do, then time management is often one of the best strategies to help you get organized and prioritize your tasks for the day. The last method I'm going to talk about is infection control issues. And with this one, we just always see the infected patient last, whenever possible. If you have a patient who has the flu and they're on precautions, you save them for last, unless they are calling out and they need something and you've got to go in there right away. You should always see them last. It doesn't matter how skilled we are, how long we've been working, how good we are at what we do. With application of, protective equipment and isolation, gown, mask, gloves, that kind of thing. Doesn't matter how good we wash our hands. There's always still that possibility that we're going to pass on, that infectious agent to somebody else, especially if one of those other patients that we're caring for is immunocompromised. So we definitely wouldn't want to go see the flu patient first and then go into the room of the patient who just had surgery yesterday, because we know that we have a surgery patient, they have an incision, and surgery itself makes them immunocompromised, so we would be exposing them and putting them at a greater risk of contracting the flu. So, just keep that in mind. TB patients, MRSA patients, you would never want to go see them first. And the only exception to that is the ABCD rule, or the time management if they call out and they need pain medicine or they are nauseated, okay? And you'll see, a lot of times, you'll see nurses do this. They organize their activities, okay? Let's say they have a patient who's got the flu and they're on isolation precautions. You go in the room, you got to put on a mask and a gown and gloves. But that patient also needs to have a glucose checked, and they've also got 8 o'clock meds. You've just finished report. The patient calls out and they need pain medicine. They're hurting. So you will see many times, you will see that nurse go ahead and group activities together. They've got to do their initial morning assessment. They've got to check the blood sugar. They've got to take in pain meds and the 8 o'clock medications. So they'll go ahead and they'll get both medications and the glucose monitor ready. They'll gown up, go in the room, do their assessment, give the medications, and check the blood sugar all at one time. Now, they're not following this infection control, seeing that patient last, because that patient had an immediate need. But they are also combining other time management techniques. Given that 8 o'clock med, that can be done, and then getting the blood sugar checked, getting those things out of the way, with the priority of seeing the patient, doing their assessment first. So you see how you can kind of combine some of these techniques. But unless the patient calls out specifically, our infected patients should always be seen last. Okay, this is the end of the first lecture. I hope I have explained things. I hope I've answered some questions. The way the audio lectures, the way I really want this to work is for you to write down any questions or things that aren't clear, and we will endeavor in class to go over that and reinforce the material. I will not re-lecture on anything, but if you have questions about something, certainly write it down and bring it to class, and we'll try to clear up misconceptions. Okay? So I hope you enjoyed it, and let me know if you need anything.